Hello, everyone, and thank you so much for joining us. Before we get started, I do want to let you all know that this session is being recorded. If you do not consent to being recorded, you are asked to drop off the call at this time. Thank you so much, and we'll wait just a couple of seconds. All right, glad to see you're all sticking around. Again, welcome. We are in session 2, data access challenges during the COVID-19 pandemic, lessons learned and roadmap to the future. My name is Darby Gallagher. I'm a member of the Miami Tribe of Oklahoma, as well as a project coordinator with the National Indian Health Board. I will be your moderator for today's session. And we are joined today by David White from the Rocky Mountain Tribal Leadership Council. David will highlight the limitations of COVID-19 data and help us explore data-driven solutions on tribal land to improve public health capacity. His presentation will look at the evolution of COVID-19 data and how Rocky Mountain's Tribal Epidemiology Center used it to share technical advice with tribal health departments. Before we begin, I have just a few housekeeping items. At this time, all participants have been asked to mute their phones or their laptops. Today's session is being recorded and will be available to view post-institute on the NIHB YouTube channel. Please leave yourself on mute until the Q&A portion of today's session. And if you do have a question for the presenter, please leave yourself on mute until the words are so hard today, guys. I'm so sorry. If you do have a question for the presenter, please use the chat feature in Zoom. By clicking chat, you can communicate with the presenter and attendees at any time during the session. If you do have any troubleshooting issues, go ahead and use the chat function for that as well. And lastly, to leave the webinar, all you'll have to do is click leave meeting. And I'll go ahead and introduce David and we can get started. So David White is an epidemiologist for the CDC Foundation assigned to Rocky Mountain Tribal Leadership Council, Tribal Epidemiology Center. Before joining RMTEC, David was a COVID-19 epidemiologist and chair of the vaccine strategy team for the Hopi tribe. He was also a global scholar for Tulane School of Public Health and served in the Peace Corps in Cameroon. And I will go ahead and turn it over to David.
Hi, everyone. I'm David White. So as Will said in my introduction, I'm the CDC Foundation Epidemiologist, and I'm assigned to the Rocky Mountain Tribal Epidemiology Center. What we're going to be looking at is Rocky Mountain Tribal Leaders Council, the text, use of COVID-19 data, that limitations, and what we're trying to look forward in the future. So first things first, I am going to cover this. So this is a statement from the CDC Foundation for my funding. So to explain as a means of housekeeping. So David White's presentation is supported by the Centers for Disease Control and Prevention of the United States Health and Human Services as part of the financial assistance awards totaling $268,939,536, with 100% funded by CDC/HHS. The contents are those of the authors, myself, and do not necessarily represent the official views, nor are an endorsement by CDC/Human Health Services or the US government. I think it's important to have that that needed to be stated before we move on to getting more forward with the presentation. So, so the core of the presentation is that we're going to look at RMTEC's background, the function, what it is, how it came to be, the driving forces behind it, as well as what are the services that Rocky Mountain Tribal Epicenter produces, and then we're going to look more specifically at COVID-19. So data management, role of RMTEC as our successes, our failures, and our opportunities. So we're gonna try to move forward and try to see what we would like to see moving forward. So let's look at the structure of the RMTLC. So at the top, you have the tribal leaders, and then you have the executive committee, executive director. And then from there, you get inside the executive director, have our institutional review board. So where we would, if you were going to form a study or anything like that, you would need to go through them. And then you would have our other encompassing organizations with our operations, finance, human resources, BIA. We have tribal opioid response, epi capacity, the Rocky Mountain Tribal Epidemiology Center, good health and wellness, and special projects. So we cover a lot of different sectors as we tried for a kind of full approach to the health of Rocky Mountain. We're going to look now at tribal epidemiology centers. So it was established via Indian Healthcare Improvement Act to elevate the health status of tribal and urban Indian communities. So the original 4 techs were established in 1996, and now 12 techs exist nationwide. So these techs function independently, but they form an overall group of techs with the Tribal Epidemiology Center organizations. So our core funding is through cooperative agreement with IHS and their Department of Epidemiology and Disease. Yeah, so then this is tribalepicenters.org, where you can get a more in-depth description of all the 12. But here's the map of all of our areas. So you can see how it's mostly separated geographically, and we serve Rocky Mountain. So tribes affiliated with Montana and Wyoming is our service area, and our office is based in Billings. So to gain public health authority status, that was formally established in 2010. The Affordable Care Act formally recognized all techs as public health authorities. And that's important for data sharing. So that ensured that the Health and Human Services Department would be directed to give data systems and protected health information to techs. So as well as the CDC is directed to provide techs with technical assistance on request. And each IHS area must have tech access. Okay, so for the RTEC, we have 7 essential functions. So first one is collect data. It's the core of a lot of epidemiology. So they come from 2 different organizations. We either have a data sharing agreement with the tribe. So that's a formalized agreement between tribal leadership and the techs on what data can be shared and collected, which is maintained by the tribe. And then there's also publicly available resources. So that'd be your state data, national data, organizations from that. So then we also then evaluate data and programs. So that's our analysis, our assessments, our evaluations, and our methodology in doing so. We then move into identifying health priorities with that, health priorities. So using that data into an actionable situation. So then we make recommendations for health service needs using public health methods. So our methodology, again, coming from epidemiology and health services. So, and then from there, we make recommendations, and then we provide epidemiological technical assistance to tribes and tribal organizations. And then finally, we provide disease surveillance. So that's our 7 core functions, and all things that we do fit into one of these or multiple of these goals. So our mission statement is to empower American Indian nations and urban Indian health centers by building community-driven public health and epidemiological capacity through outreach and creative partnerships. So empowering tribes with reliable data for public health planning and program development. So with data, you can try to form your baseline, your backbone of any type of health intervention. And so RMTEC really wants to set that foundation for tribal health response. So our tribes we serve, so as previously seen, we were on both Montana and Wyoming. So Blackfeet, Crow, Fork Belt Map, Flathead, Fort Peck, Rocky Boy, and then on Wind River Reservation is shared by 2 tribes, with Eastern Shoshone and Northern Arapaho. They are in Wyoming and the remainder are in Montana. Oh, and as well as Little Shell. I'm sorry to forget, I thought I clicked them all and knew I was missing one, Little Shell, which is also in Montana. And then from here, you can look into the epicenter more from a logic flow map. So we have evaluation, technical assistance, recommendations, and public health promotion. So from there, you can see where things are moving and how our organization outside of tribal health departments can aid in public health by providing recommendations and having and providing any technical assistance. So from there, we're going to look at RMTEC's COVID-19 response. So what we're going to see is we're going to look at all the different elements of RMTEC's response, from the data to public health promotion. And so we had a very variety of response to help our community. So first and foremost is we have a weekly report. So that's created using our public available data. So that's state, IHS, and CDC websites. So we then localize that data for RMTEC. So we're trying to make it a more approachable scenario, and all tribal health directors get an update every week from these resources. So that's going to have our testing, our mortality, our vaccine data in the areas in which they're found. So the county data, state data. From there, it gives a good geographic location. However, it's lacking racial classifications. So it's hard from then to distinguish it from on reservation. So it lacks that. And we also have a COVID-19 data aggregate report. So we model from here using our public access data. We keep a detailed record of all of the cases over the last year. So that's in the darker purple 2020, lighter magenta is 2021 and 2022. So we're able to keep with that. And as COVID is moving into more of an endemic cycle, we're looking to show where that baseline is. What is the year in, year out, more seasonal trends of COVID to really understand what are our peaks and what are we seeing long term. We also have a daily dashboard, so that's just updated on a daily cycle. This also unfortunately lacks racial data, but it does demonstrate the situation in COVID with disease curves and hotspotting on maps of our total cases, deaths. It also has some vaccine information. So we can have more of a geographic understanding using public information. And then from here, we also have a tribe-specific biweekly update, which we have under an agreement with CDC using their case investigation strategies. So every 2 weeks, we get a data update from CDC. That gives us using their case investigation data. We have information on cases, mortality, hospitalizations, and information like that. So we package it into an aggregate report that is then sent to tribal health directors on a biweekly. So we send it so they have a specific understanding. So it's set up, this is, we have both an aggregate, which was actually our whole service area of Montana and Wyoming, but then we also have underneath that are tribal specific one. So the first bar is for the tribal health directors. I got my start in a tribal health department, and I know that tech director and tribal health directors have so many emails that we made sure that we had this bar there that in 20 seconds they could just look across, and typically we have the percentile increases. So if they know if everything is going up, they get a red arrow plus the amount of percent that it increased. And if things are not increasing, then you get a green equal sign. So if you see green equal signs across, they don't even need to read the rest of the report. But if they start seeing red arrows, then they can get into the deep dive into their data, as well as there's also going to be disease curves that's going to show the general trend over time for the tribes. The problem with this is that it's every 2 weeks, and COVID, unfortunately, moves through communities much faster. So if you're getting data of cases from 2 weeks ago, you're already behind the curve. So they have an understanding of the greater trends, but it's hard to get out in front of COVID when you're 2 weeks behind it. So now we're talking about this. So we have our faster public access data, which unfortunately lacks race, so it can't be tailored more to Native American populations. And then our limitations, and then our biweekly report we're lacking negative COVID-19 tests. So we don't have an understanding of percent positivity. And that's going to be your kind of your greater, that's one of your first triggers on a COVID response, is when you start seeing that your percentage of tests coming back positive. That's your first inclination, and we don't have that on our biweekly data. So understanding we had data, but we also, and RMTEC, we had a larger, more comprehensive response. So COVID-19 resources. So not only did we give data, but we also gave our PPE, and we allocated that through our CDC Foundation. We also were fast on our education, knowing that what data we had could give to it. So we also created flyers designated for the tribal communities. From there, we try to have more targeted information from there to give to our tribal health directors. And then from there, they can disseminate it out. So whatever they want on any type of targeting, whatever type of any type of information that they view as valuable, then we can give them that information. And this was something that was a direct ask from a tribal health director. Obviously, I'm not going to. This is in which the tribal health directors were like, we have a high diabetes rate, so we were able to tailor our information accordingly. From there, we had a diabetes and COVID information, talking about Alaska Native, American Indian and Alaska Native diabetes rates, and how that's going to impact your COVID as a means of using data as a risk communication strategy. We also had survey analysis. So we used SurveyMonkey to gain information on motivators, and we're using that to tailor messaging as well. That was posted through social media. That was nice because it was able to, that people could self-identify under race. And then from there, you can get a more targeted messaging. So on there, that it affected our survey. What was interesting with that was not only did we evaluate our barriers in Native communities, but we also looked for motivators, because there are people who are being vaccinated, and we wanted to know why, and would that then be an effective strategy of communicating. So COVID-19 challenges. First and foremost, this is our first major pandemic since the establishment of public health authority. We were given public health authority in 2010. most public health organizations, they were looking at COVID-19. They were mostly using their playbook from swine flu, which we did not, RMTEC was not a part of. So this was kind of our first time strategizing in infectious disease. We typically generate our reports from the electronic data market from the Indian Health Services, which is really effective in looking at our injury and our chronic disease. However, EDM is updated annually. And like I said earlier, that we were always perpetually behind the 8 ball with a bi-weekly information. Now EDM is only happening annually. And that, of course, gave us a much greater challenge. And so from there, also data is also governed by our data sharing agreements with our tribal public health department. So we only do what is asked from the tribes, and we make sure that there's a secure bridge on data that's being shared. So from that's going to be some challenges into what we were looking at. So, but we have also looked at using data as an indirect effects of public health. I think that this was a major sticking point for me. I'm talking about COVID, was that it didn't happen in a vacuum. Obviously, COVID affected much greater comprehensive of our health profile. And so we are using our major EDM sources to really look at the indirect effects. And from that, we've used it for our chronic disease and our public health training. So I'm currently writing the chronic disease report. And so long-term indirect effect is what we're seeing in chronic disease. I've been looking at hospital capacity and our encounters data. And that's something that the EDM is showing a very long-term effect in regards to that, as our encounters data has still took a big dive, and we're seeing a clearer picture. And now that we're moving into the later stages of COVID, we're now being backlogged in our chronic disease. And our EDM has been actually one of our biggest resources in finding what's going on. So our 5-year reports on chronic disease, we're seeing the difference in the encounters data from there on a year to year when we saw the impact of COVID on chronic disease. And then we also have used monthly lecture series and skills trainings, so ArcGIS and Excel, to really bump up not only our own data information capacity, but we've been training tribal health departments of any type of data that they had, what they can use with it. So ArcGIS is a geographic information, and Excel is one of the most efficient for maps and spreadsheets. So goals post COVID-19, obviously we're still battling COVID-19, BA5 has been affecting a lot of us. We're seeing increasing trends. And so what we are looking for in more endemic, when we move into a more endemic, is we're looking at epidemiological infrastructure in America, with majority of tribal health departments lacking an epidemiologist. We've tried to bypass that by giving a free lecture series and trainings for the fundamentals of biostatistics, epidemiology, and public health. So I put on my lecture hat, and I've done Epi 101 and public health lectures. They're always free for tribal staff. Biostatistics, that presentation is very good. As one of my staff members, and she always knocks it out of the park. So if you ever see that, because what we're seeing is there's just not a whole lot of epidemiology. And so without it, you kind of start to see the value of data after these things, because something I always talk about in the Epi 101 lecture is that epidemiology kind of focuses on it's kind of like your point guard for a public health response, and it distributes data to the organizations that can form actionable responses. So Epi gets data, analyzes it, targets it, packages it, and then they give it down to, you have your policy, your health education, and how all these forces then join together to make an adequate public health response. So it's something that we try to teach in our lecture series is how public health is all being formed together and how at that root of it is then our data. Next pandemic. So I think that that's always a discussion with COVID, is that too many people are like, well, COVID's over now, let's go home. And that's our understanding is that we have to take inventory of what did we do wrong, but also what did we do right? How did we form solid epi strategies, and how did we as a tech, how did we put tribes in a situation where they were going to succeed? How did we put them in a winning organization? How did we set them up for everything? And so we're looking at limits of data sharing under HIPAA of something that we wrote, and something that we've seen in the Government Accountability Office was that tribes can request it under HIPAA as well as text. If you have a public health authority, you can request public health information. The problem is if the organization doesn't feel like giving that data, they don't have to. So there's a lot of questions on how can we form an effective data sharing agreement between parties, and especially moving forward, we want to see a movement forward on real-time data. So much, as I previously said, with this being our first major pandemic, is that so many of our other successes in the text were more related to chronic disease and injury and things that are very slow, longer term projects with diabetes, heart disease, that on a year to year, you're going to see some general trends, but it's not like COVID where an infectious disease kind of can erupt very quickly. And having that real-time data really can set people up in a situation where they can get that data, get it analyzed, and then create actionable programs faster than COVID. And I think that that's the major focus of what we're looking into. I think that's it for me. Are there any questions? Yes, it is free on the RMTEC website. So we make sure that all of our information that's non-tribal specific, so anything that's more for a general Native American audience on our education, we make that publicly available to anyone. So if we're using publicly available data, publicly available information, we can make these flyers and then we send them out. So so it's important. Obviously, we'll tailor things that can get sent to the tribal health directors. Those won't be available on the website, but things that are things like that diabetes one, I actually got it. I didn't even need to talk to my communications person. She was out of the office. She was like, "Oh, you just go on the website," and I found lots of them. We have a very comprehensive communications department, so there's a lot of flyers.
You're working with tribes in Montana, Wyoming. How do you gather information for any tribe members that are off the reservation or living elsewhere? If they were to come out program.
It's often challenging for off reservation. So what we do have in urban IHS unit in Billings, and that's kind of the main one for off reservation. Data from Billings, complete Billings area it will be present, and that's only for they'll cover the whole area. So thanks to anything that's IHS related, which is going to get the more general picture. Obviously, off-reservation gets more challenging, and then now we're facing the problems with testing data with at-home testing. It's kind of hiding behind that we're only seeing more severity when people are starting to get hospitalized.
Waiting for some more questions to come in through the chat, but I do have one I can ask you now if you want.
Yeah.
So let me pick which one it is. From your experience, what are best practices for collecting complete and accurate data for AIN populations, just like through what you've seen, what you've done?
I think the gold standard data is EDM data, electronic data market from the IHS, because it also includes infectious disease data. You're going to see more general trends because it's more annual, but we have had talks about that they're looking to move it into a quarterly, so instead of annual updates. So that's a step in the right direction because that data is very comprehensive, localized, regionalized, and has great IAN comprehensive data. It's almost overwhelming how much data you have because you have all the hospital data and things like that. But as an epidemiologist, you can never have too much because you always cut it back and localize and things like that. So that to me is always our best data information.
This is just another question because I'm nosy.
Yes.
When you're requesting data, do you have to put in, is it like a FOIA request or is it just like shooting an email to HHS and being like, hey, can we get some data?
Oh,
like
yeah, so it's a formal agreement with the, yeah, all these things have longstanding data agreements are very important and sacred, and you have to have a very long process, but it's for the best. Obviously these are very sensitive issues, and so I'd much rather have a very comprehensive paperwork on that.
Sure. Yeah, before working at NIHB, I did some MIP work, and when we were trying to like just request data on it, it was like FOIA requests, and and when you submit a FOIA request, they don't have to give you the data. And so I was wondering if it was like similar.
Yeah, and
nightmare process for you.
Yeah, they don't have to send you the data, and when in regards to and that's always the difficult thing. And then there's no accountability on that issue. If an organization doesn't want to send you data, they don't have to. And so then if you don't have data, you're kind of flying blind. And that's the last thing you want to do in regards to COVID.
And then I guess my last question, in your perfect world, like how would like data equity, data quality look for TECs, look for HHS, look for nonprofits, look for all of that? I know that's a big question.
Yeah, that is.
I know, I'm so sorry.
I think that there just needs to be just a realization of with regards to data. I think in the perfect world, my first step was realizing that data is the reason why you're not in the hospital. I think the whole, as an epidemiologist, it was pre-pandemic, no one knew what I did. And the whole running joke was, well, if you're sick, talk to a doctor. If you're healthy, thank an epidemiologist. And I think that understanding is that you're using data to stop hospitalization. And that I think that like in a perfect world, that it's just that acknowledgement of that data and public health has a comprehensive foot at the table in American public health. Like I think too often we just have this view of healthcare that it's you and then you go to the hospital, and that our understanding of data as a means and data-driven solutions as a means of prevention, that recognizing that and having an emphasis on that and understanding its own role would be something, I guess, the first step in my perfect right, world is that we understand what's data's role. And I think another major element, especially when I talked about epidemiology infrastructure, was I think too often our approaches in epidemiology is very research-based. We don't have this much public health epidemiology. And what I always stress is the return on investment for epidemiology, is that it's used as a data and data analysis is used for resource optimization. So if you know your specific areas or your specific populations that are most vulnerable, you then don't have to spend as much money on the populations that are less likely. So you kind of churn the wheel of becoming more and more specific to your interventions. And that's where the whole epidemiology as the point guard is, that we can use data. It's not that in regards like, oh, it's so expensive to have data, or oh, it's so time consuming, but it optimizes everything. It's that first initial step of realizing that once you get data, it can generate more data that you're getting more and more specific, that you're able to get a higher return on dollars spent on public health infrastructure. And I think that's, to me, the main focus on public health data and epidemiology, is that we're trying to optimize the response. Yes.
I don't know if you have any chat box, but in terms of like COVID-19, earlier that not all tribes will share their data or will agree to a data sharing agreement. For those that are like health educators and those that like really like their job is like community awareness materials, but you do not have an epidemiologist like background, are there like classes? I came in and use one of the classes that you all offer.
Yeah.
Are there classes available for those that do not have a public health background but may be able to like tap into some of those classes to just learn?
So our classes that we offer at RMTEC are open for everyone.
Okay.
Yeah. So, and our monthly lecture series also has we intended for just that anyone has it. So last month I was our lecturer, and it was the 411 on Epi 101, and that everyone is now hears about an epidemiologist and what is it, and it's more of like, what is the field, what are they doing, and so you know what is going on. But no, we intend our lecture series for people who have no public health background. It gets sent to tribal members that if you're just curious about it, go for it. You can learn whatever, and I think that's an important element of it. Do we have anything in the chat box?
I don't think so. For folks watching on Zoom, if you have any questions, feel free to unmute yourself and ask, or you can go ahead and type it in the chat box. And if not, we can give it a couple minutes and if you can enter the camera. Yeah.
I was just sharing that in Colorado, we had the TRAIN board. So COVID started hitting, some of us, the admin team would take those 50 hours courses. We get certificates for that. So started looking at contact tracing,
Oh yeah.
And so we have been getting questions, and I ask because we have been getting questions from state recognized tribal communities, and you know, they oftentimes don't get the same funding.
Yeah.
Federally recognized tribes.
I definitely understand state tribes actually more than federally recognized tribes, because I'm from North Carolina, Lumbee being such one of the larger state recognized tribes.
And so they often do not have the funding to bring in like an epidemiologist. So they reached out to NIHB for like resources to help with contact tracing, like what do they do with that data? They did some surveys, but they haven't been able to, you know, like what did you miss?
Yeah.
So that's kind of where I'm coming at, like if you have this data, but you don't know what to do with it, what resources, and you just identified two, like you all offer your free classes, and then you tell me Colorado has the TRAIN program.
Yes.
Okay. And so for Rocky Mountain, the tribal communities that you work with, are they able to like send you their data and you would analyze it for them?
If it's under the tribal data sharing agreement, because tribes, of course, tribal sovereignty, this is their data, their own entities. So when we have a tribal sharing agreement, it is specific of what they want to share, what they want analyzed, how that happens. We have these long comprehensive agreements to make sure that, like, understanding that their data is their data, to make sure, because make sure that it is a secure channel of which they're operating under. Because yeah, they'll send it to us to be, if they want to, they can send them to us for data analysis. They can be then sent, it'll be sent right back down to them. There's no, so if they're looking for a data sharing agreement, we can formulate one of what type of data that they're looking to send and analyze and what type of information they want. So everything for us is governed under that, because of the tribes have that is their own data, that is a focal point of data sovereignty and tribal sovereignty.
Okay, so have you all been able to link their, because I saw you said you also focus on chronic disease, their chronic disease risk population, like their hospital data,
Yes.
with their COVID data to like look at, you know, of those that had diabetes, this number was hospitalized with COVID-19?
Not so much linked, but we are able to look at our hospitalization data through our EDM.
Okay.
Yeah, so that was a major element of that. The EDM data is so comprehensive that it gives us a tremendous resource. However, it's only updated annually. So it even has infectious disease data, but you're talking about 1 year to 1 year COVID. That's a completely different organization. So we are moving forward to getting it into a more quarterly, but the EDM needs to be it's our #1 resource.
I'm sorry, I have just so many questions.
Oh no, go for it.
Your that police when you have the diabetes and the COVID. But like we have like the task force they were talking about that they do have, they didn't really put information on that. It was just, we were lucky. Thank goodness for our county nursing staff, who help them when they start first testing.
Okay.
We ran to them because they're the ones that acted and tried it a long time before they acted. So we ran to the county, our local county. So then the tribe could pick up, and then, you know, the COVID dollars came in.
Okay. But is that normal though? Like when you, let's just say outbreaks in general, right?
Mm-hmm.
Do epidemiologists often work with the command center for those type of disasters to like talk about past, you know, like your high risk populations? Who would those be? What to expect from those?
Yeah, so I can't speak as much on RMTEC because it's tribal epicenters are outside of tribal health departments.
Okay.
So typically incident command, that's going to be based in the tribal health departments. As I said earlier, I've been affiliated with the CDC Foundation for the last 2 years since the beginning of the pandemic. So when the epi positions were sent to the tribal councils, they had the decision over what they were going to do with them. The Rocky Mountain decided to send all of them to the tribal epicenter. And I got my start on the Hopi reservation. And that tribal council elected to break the 5 positions apart and send them to individual tribes based on COVID, the impact of COVID in their community. So Hopi, being a very hard hit reservation at the beginning of the pandemic, they got the epidemiologist. And so their epidemiologist happened to be me, and I've joined their COVID task force unit, and I was chair of their vaccine strategy community. But yes, as the epidemiologist, I was then on their incident command. I was part of the Hopi. It was called HERT, Hopi emergency response team, which was a joint coalition on reservation between tribal governments, our FEMA and our IHS units, and we would meet 3 times a week discussing COVID and everything like that. And then we had a weekly meeting that had chairman, vice chairman, executive director. The schools were part of it, as well as IHS, FEMA. That was our larger group, now it's called HEMA, Hopi Incident Management Authority. And so that organization would be, HERT was more her day-to-day on COVID trends, making sure that we had our supplies and our data information coming through, that we were a coordinated front combating COVID. And then HEMA had more of the, that's where we would make our decisions on our lockdowns and our policy. That was a bigger meeting. As an epidemiologist, yeah, you can be in those situations. All tribes have very different experiences, and I've certainly seen that now, as because my whole perspective was Hopi going into, and now I had to understand that all tribes are different. They're going to have different relationships with their techs, and they're going to have different relationships with their counties and with their organizations. And you see that especially with the vaccine rollout, with the in regards to count states versus federal, because tribes had elected of what type of avenue they wanted to get their vaccines from. You could elect to go through IHS, or you could elect to go through the state, and you saw tribes gauging that and which ones that they were going to pick.
Any more questions online? We'll do the chat box one more time.
I have a question. My name is Dr. Leland Leonard. I am working for the Southern Paiute Tribe in Tuba City, Arizona. And I heard you say that you collect data for the Hopi tribe. Is because Monkopi is in the Tuba City Healthcare Center. Do you collect data at Monkopi?
Yeah, so when I was there, yes. So we had a data sharing agreement with IHS on Palaka, which gave us daily reports, and then we would also get reports from Tuba City Regional. And that would be because people would then classify on which tribe they were affiliated with, because yes, Monkopi and even other elements of the reservation would go to Tuba City, because like Ho'otvela and Sapalavi would also frequent, and to some degree Kokosmovi would frequent Tuba City. But yeah, we had it both status systems would share data. We would get information from both, and then we would combine it into one singular Hopi report. Back when I was there on Hopi in 2020 into 2021. Did that answer your question?
Yes, you did. Thank you so much.
All right, anyone else?
Many people do we have in our online?
8 participants online.
When I was this year, it was being urban, urban collecting data. Collecting data is very hard. We also have our 2 sister organizations that are in the center, they're a better resource. So we're always looking for ways to try to get tribal members in the metro area get their information, stats, data, so that we can provide our clinic and also services. So while I'm here, one of the reasons, one of the things I try to do here is speak on the tribes and say, if you have any tribal members that are in the metro area, please make sure you can at least check in with us. Usually, somebody who doesn't need health care, they have fires and better from their employer, they're not going to need our services more than likely. So, which is fine, but what I'd like to do is tell people who try, especially more in your area, Montana, if there are tribal members in Denver, come and see us at different family, different health resource. Different ended family resource, different family services. And at least register with us so that we know that you are talking here. And then when we do have COVID, we do have a fairly active child numbers in the metro area. So it's, because Colorado's unique that there are no recognized travel lands except down in the southwestern border of Colorado. So we have made some strides in the state of Colorado and the Colorado Indian Affairs Commission and Affairs. They're trying to get more data. In 2020, we all know that was the first year that I can remember Native Americans being listed as other. So really, that's an eye-opener.
Yeah.
People go to the clinic or even the emergency room, all right, white, black, Hispanic, non-Hispanic.
Yeah.
And sometimes, and it's by no means I'm not blaming the healthcare, but it's not really they're doing their job at that time. So they'll list as non-Hispanic and they'll move on. So there's no records if they're very served, for being provided service there.
Yeah.
So one of the things that I'll try to do here while I'm here is speak on the tribe, really come in contact with you, obviously, to take this back here. We're taking tribe members that are in the Peru metro area, come and see us, either us and Denver Indian Health and Family Services, my word, Denver Indian Family Resource Center, or the Denver Indian Center. At least come by and register with other organizations so you're there. I'll use like their urgent visit job and healthcare, which is terrific. But when something like COVID happens, or we're trying to service one of our Indian housing programs, we don't have any data. So we go to different resources. So, how many Native Americans are actually in them? And that's where we're kind of grasping across and gather data. So, just communication is always a good thing to share in meetings like this and organizations. So it's not fun out there. Thanks.
Yeah, absolutely. Thank you for sharing.
Organizations.
Right.
Yeah.
And like when I was working at New York, part of DC and started working at NHB, we were startup, we were brand new, so not a lot of people trust us yet, but we all went in with super good intentions. Didn't obviously want to step on any toes, but anytime we tried, specifically the project I was working on was on MIW, and anytime we were looking for data, we would always see that there was racial misclassification. So you would never get Native, we would always get Indian, subcontinent in India, or it would just be other, or just completely, it was limiting the race down. And you're like, well, okay. And I was trying my hardest, send FOIA requests, and no one responds, and it's a nightmare. All right. Let's see if we don't have any more questions. Wanna end it out?
Yeah, if there's no more questions, I want to thank everyone for being here, both online and in person. I think that I'm happy to discuss any type with data, and I'm very happy for people coming here and asking great questions. And I just want to thank National Indian Health Board for giving me this opportunity to speak. All right, everyone, I hope everyone takes care and has a lovely day.
Thank you.